Hello, my name is Smalley, and I'm here to talk you through a basic aorta exam using point-of-care ultrasound. The indications for this exam is to determine whether a patient has an abdominal aortic aneurysm, also known as a AAA, or an aortic dissection. During this short lecture, we're going to focus on the abdominal portion of the exam and identifying AAA, but we will also talk about images that you can see that can be consistent with aortic dissection. Just so you're aware, there are other images that you can obtain in the cardiac views to assess the aorta. The indications for this exam are sudden onset abdominal pain or back pain, which could be consistent again with a AAA or a dissection. Patients sometimes present with sudden onset chest pain that radiate to the back. Other indications are concerns for an aortic catastrophe in the ICU or the emergency setting. Concern for aortic size, and this could be an indication if you're concerned a patient may need emergent surgery. And then in the outpatient setting, we're frequently seeing this now with our outpatient providers who are performing bedside ultrasounds for a one-time screening test for men between the ages of 65 and 75 years old who have smoked in their lifetime as part of a preventative medicine initiative. The probe that you should use for this exam is the low-frequency curvilinear probe. Again, just to review probe placement, when you're using the curvilinear probe for this exam, you'll want the probe pointing towards the patient's right or towards the patient's head. All probes have a marker on one side of the probe that can help you place the probe in the correct position. The required views for this exam in order to fully assess the aorta are the following 5 views, and this is for a basic bedside point-of-care ultrasound exam. We recommend that you obtain a proximal, mid, and distal view of the aorta. Additionally, once you've identified the distal aorta, you should move your probe down towards the aortic bifurcation to assess the iliac arteries. Last but not least, you should place your probe in a long axis view, also known as a sagittal view, to get the aorta in a long axis. Pictures next to this slide indicate where those probes should be placed. The first view that you should obtain is the aorta proximal view. You're going to want to place your probe just underneath the xiphoid process in the transverse plane. You can place your probe just left of the midline and put that probe marker towards the patient's right side. Keep that probe perpendicular to the abdominal wall. Once you've identified the aorta, the distance between the walls should be less than 3 centimeters, and you should measure this distance. As we move through this presentation, we'll discuss a little bit more about measuring. One of the most important things to know when you're performing this exam is to look for something called the spine sign. Just behind the aorta is a hyperechoic line consistent with the spine, and next to the aorta is the IVC. You can use pulse wave Doppler to place over the vessel to ensure that you're over the arterial vessel and not the venous vessel. The second view is the mid-aorta. All you're going to do for this view is take your proximal view and slide the probe down just above the umbilicus and between the xiphoid process and the transverse plane. Similar to the proximal view, you're not going to change any direction of your probe marker. You're going to keep your probe marker to the patient's right and stay perpendicular to the abdominal wall. You're going to want to look at the aorta and make sure that there's no dilation. Last but not least, you'll want to get that distal view of the aorta, which is usually just above the umbilicus. Move the probe distally into the transverse plane and keep your probe marker to the patient's right and probe perpendicular to the abdominal wall. You can see in this image to the left that a measurement has been done where the scanner has measured from the outer wall of one wall to the outer wall of the other wall and obtained a measurement and saved it to the picture. Again, just to reiterate, you want that measurement to be under 3 centimeters to be considered normal. After you've identified the distal aorta, you can move down to the aortic bifurcation. This is where the vessel splits into 2, and you should see 2 vessels. Again, you can use pulse wave Doppler to confirm whether it's arterial or venous if you're unsure. Keep the probe in the midline and stay with the probe perpendicular to the abdominal wall with the probe marker to the patient's right. The difference for the bifurcation is the distance for each iliac artery should be less than 1.5 centimeters to be normal, and you will measure from outer wall to outer wall. Last but not least, you want to obtain a sagittal view of the aorta. I recommend that you actually go back to your transverse view and place the aorta in the middle of the screen prior to turning the probe into the sagittal view. This ensures that you stay on the aortic vessel and not move to the IVC. You'll turn the probe in long axis from the transverse plane, confirm that you are on the aorta, looking for that thick-walled, non-compressible vessel, and you can confirm this with pulse wave Doppler if needed. Again, measure across the vessel, demonstrating that less than 3 centimeters should be normal. Here are some examples of pathologic images. In this example, you see an aorta. I want to bring your eyes first to the spine sign, which is at the bottom of the screen. And just above the spine sign is a large vessel that is enlarged, and when it's measured, it's greater than 3 centimeters. Here is an example of a AAA in the mid-aorta region. And here is an example of a dissection flap consistent with aortic dissection. So in this image, you can see a hyperechoic area in the middle of the aortic vessel. This is abnormal and could be consistent with a dissection. If a patient is presenting with the right symptoms, this may be a study that you want to obtain to see if you can see a dissection flap. Remember that when you look at this image for a flap, if you see a flap, that can be indicative of a dissection. But if you don't see a flap, it does not mean that there's not a dissection present. You should always get the confirmatory CT scan. Here's another example of an aortic flap, a dissection flap in the middle of a vessel. It's difficult to see, but in that area where there's a marker, you can see there's a small hyperechoic area consistent with a flap. Another example of a pathologic image with a dissection flap. In this image, there's color flow over the aorta to help identify. Last but not least, here is an image of a AAA indicating an enlarged aorta. And here's an example of a AAA with a thrombus. Closing comments about this exam. Make sure that you are on the aorta and not the IVC when you're in long axis. Novice scanners will make this mistake frequently, that when they turn the probe from the transverse to the sagittal plane, they will sometimes come off of the aorta and land on the IVC and measure the wrong vessel. Remember that the aorta is thick-walled and non-compressible, and you can use those characteristics to help you ensure that you are identifying it. But the easiest way to make sure that you're staying on that vessel is that when you turn your probe from the transverse to the sagittal view, that you keep that aorta in view the entire time. You want to make sure that you don't measure the inner lumen of the vessel. As I showed you with some of the pathologic images, many times there is clot that is around the wall of the aorta. While the lumen may be under 3 centimeters, the aorta itself could be larger than 5. And so it's important to make sure that you identify the lateral walls of the aorta and not measure the inner lumen. We mentioned this, but the dissection flap can indicate an acute dissection, but the absence of a flap on ultrasound does not rule out dissection. Retroperitoneal free fluid cannot be diagnosed with ultrasound, so make sure that if you're concerned for a retroperitoneal bleed or a rupture that's retroperitoneal, that you obtain the confirmatory CT scan, which should be obtained for all of these exams after you identify pathology. Last but not least, greater than 5 centimeters is an indication of vascular consultation for repair. Many times in the emergency setting, we are concerned for acute rupture or potential rupture, and we will get vascular surgery involved if we are concerned at any time that the vessel is greater than 5 centimeters. Thank you very much.